Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 135. This is a really interesting episode. I think, I always say they're interesting because they really are. But before we get into it, I just want to, for the listeners who don't know us well, we started this podcast in, I think, 2018, and our website is toughtotreat.com. So we don't expect every listener, to listen to all of the episodes, although I know some loyal listeners do listen to all of them, and we thank you for that. But if there's a topic that you want to hear about, like shoulder pain, pelvic girdle pain, stress urinary incontinence, neural tension, whatever it is, go to our website, toughtotreat.com, and type in the search bar, and you'll have every single episode that had those keywords in there, or a topic devoted just to that. And while you're on there, we have a clinical pro PDF that I wrote, as well as sleep and persistent pain tips that Susan wrote for your enjoyment, your reading enjoyment. If you can just sign up right on the website. So this episode is about, I thought that we would talk about patients that who are a little bit older and who have this quote unquote diagnostic whatever diagnosis of knee OA. And so this, I will talk about a little bit more about the treatment aspect, because I think diagnosis is somewhat probably straightforward with knee OA, but it's something that we haven't talked about in a while. So we're going to talk a little bit more about how you actually start treatment with people like this without exacerbating their symptoms. We hope you enjoy it. Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 135. How are you today, Susan?
I'm good. I'm good. How are you?
I'm good. It's raining again here, which I have to say I'm happy about because we've had so little rain, but very foggy and very rainy.
Yeah, it's rainy. It's rainy here too. We've already had snow in Michigan, and we've got rain now, and just it's that time of the year.
It is, and we haven't even had the leaves change much here in the city. I mean, Central Park, I have a view of Central Park, which I'm very lucky to have, but it's still quite green, not many. I think we're going to be late bloomers this year, I think.
Well, Michigan, at least in northern Michigan, we're just about done. We've definitely peaked and past peak. We've had 3.5 weeks of just outstanding colors. So we wish everybody fun things in the fall and all the activities that go along with it. So what are we talking about today?
We are talking about, as I mentioned in the intro, a patient of mine who is 81 and wants to run a marathon again. God bless him. And he has, and he's pretty active, and he has knee osteoarthritis, basically. So, in the sense, is he like a complex patient, tough to treat? Sometimes these guys are, or women are, because, they're standing there, their knees are bent, they can't straighten them out, and they want to be able to walk and run and squat and bend over. So I'll just give you a little bit of his history, and then we can talk about some treatment that would be a nice progressive treatment for somebody like him, because people who, when you go up and down stairs, and that's mainly what his issue is. So I will give you his background. He's 81. So as I said, he wants to run a marathon again, and he hasn't run a marathon in years. So is that realistic? I don't know, to be honest. It may be. He does these sort of typical calisthenics moves in the morning. He's, moving around, he's twisting, he's bending, the typical sort of stretching routine. His past movement history, very active as a young boy. He played semi-competitive soccer or football in his country for many, many, many years. And I'm just looking at my notes here. I think his first injury was like ankle sprain. So he's had bilateral ankle sprains. I mean, he's a soccer player, so he's had multiple injuries. And he actually sprained his wrist 2 weeks before he came in to see me. I don't think that's related. Every time he either bends his knee in an open chain position or a closed chain position, like a squat, that would bother him left more than right. So it was, the left knee started probably about September, probably 7 months ago, 8 months ago. And the right knee started 2 months ago.
And it's with bending.
Yeah, open chain, knee flexion, and closed chain squatting. Going down the stairs was worse.
Okay.
General walking is pretty okay, actually. I thought it was interesting with the open chain. So the Advil and the occasional aspirin will help. Of course, he said to me, Erica, I have bone on bone. And with everybody's, I'm like, oh, who told you that? He's like, oh, my doctor. I was like, oh, I said something like, oh, those are helpful words. I was just like joking. I was like, but he's a good coper. And he's the kind of guy who'll be like, oh, whatever, bone on bone. Oh, I'm going to keep moving. So those words, quote unquote, didn't hurt him. But I hate when doctors say bone on bone. There's another
Right.
way that, right? It just drives me crazy. He said
Well, and I
last,
think that also brings back up, like when you were talking about, is it realistic for him to want to run a marathon or not? And it's like, well, it's really not up to us. It's up to them, and if we, one of the things that I've always said, if you argue for your patient's limitations, then that's what they'll have. And you brought him in and we're very open with him, like, those are unhelpful words, and yeah, let's see what we can get going, just
right,
kind of go with it. Who knows if he does it or not, but it's not our place to say you shouldn't do it.
right. Oh no, I've never. Yes,
It's,
exactly,
he would have to be, my question would be, if we can get you going, let's talk, about getting you to somebody who can help train you
exactly.
correctly to get ready for something like that,
Yes,
so
yeah. No, I agree. And
awesome.
he's very he's active. I mean, this guy can move. Okay,
Hmm.
and so I was like, oh, you want to run a marathon? Fantastic. I was like, let go for it or whatever. So I wasn't.
Hmm.
You don't want to judge people, especially when they have a history of that kind of a history of marathon running. So, in 2021, he went to see a podiatrist who gave him orthotics.
Okay.
I didn't sort of. That's he's had other injuries. He's had knee issues for many, 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 many years. Okay. He has low back pain, pretty much stiff low back pain, secondary issue, and just sort of some right hip pain. Okay. So for him, it was really his knees. And were they related? Everything? Probably. But I just think he was just very stiff. And so the exam was he basically stood there with both of his knees in flexion. I was like, can you straighten your knees out? Just to see if he could straighten his knees out. So at this
Hmm.
point, you're thinking, is there an articular issue? There definitely was, for sure. He's stiff. He has a stiff joint. He's 81. Um, and so he tried to straighten his knees out, and he could actually do that. But he's like, well, that feels kind of weird. So I said, okay, just relax, relax. So I did have him. He was pretty much weight bearing on his right side in standing, his center of mass. And so what I do with people who are sort of coming in, especially at his age, I want to see if they can get full extension, knee extension. So I'll test it in like a squat to stand, or I'll test it in a body twist as well to see when they go into, let's say you're going to the right, if that right knee goes into that sort of screw home or that tibial rotation as you go all the way to the right. And I'll just see what their strategies are for that. And in standing, he couldn't maintain the full knee extension, but he could get there. It was a bit stiff, and I didn't have my hands on him at that point. So I just had him do some general movement. I had him squat. Squatting was really tough for him. He could get down there, but I think we did an episode kind of a while ago, probably a couple of years ago, on squatting, on that research piece that came out, Susan, about how we need to get
Hmm.
our patients to full
Hmm.
squat. And so he needs to go there, but he goes down the stairs, but that's single limb loading, especially down like a
Hmm.
subway stairs here in New York. So he could squat. I had him go a wide base squat that was easier. I had him go a narrow base squat that was harder. His feet were also relatively rigid, more on his right than his left. His left was his sort of it was more of a symptomatic side, but the right one had started, as I said, more recently. And so then I had him do the body twist, and I just saw like, so when people body twist, sometimes they keep their feet really planted and they just try to move with their hips and the rest of their body. And he really wasn't moving. I was like, just let your knees, let your feet move. You can sort of turn them in and out, I said, and just move. But he wasn't really moving his knees at all. They were really rigid,
Hmm. Holding them stiff.
really exactly. And then without getting into too much technicality, you just had there was no, knees don't like to rotate, but you need to have some form of tibial rotation and femoral rotation when you're body twisting, right? He didn't have that both sides. They were pretty equal to both sides. And I noticed I had him do it facing me, and then I had him turn around and face away from me. So I could see, sometimes I like just to kneel behind him and put my hands on like the joint line on both sides just to see if there's any kind of compression or muscles turning on that shouldn't be. I sort of train the vision first, and then I'll put my hands on them. And I just saw his hamstrings light up, which doesn't surprise me at the end of the day. He probably has weak quads, not weak quads, inhibited quads. So do you have any questions, or should I keep going? Because I want to talk about the treatment really.
Yeah, no, I think it sounds pretty straightforward. People with that have pain, tend to hold the, muscles switch on and muscles switch off. And, he probably was overworking the muscles around the joint in response to the protection requests from the brain. And, so I think that's pretty straightforward there.
Yeah.
And, maybe just, and it wasn't really so much of an unwillingness to move, but maybe just a learned pattern that has, the stiffness makes it worse.
Yeah. Yeah.
It doesn't make it better when we hold things stiff. It generally makes things worse. So, but I think that's a great technique to put your hands, just on the joint lines and just feel what's actually happening there.
Yeah.
We can feel so much through our hands that I think it's important to do that, hands on the hips, hands on the back, hands on the shoulders, what's really happening.
Yeah.
Okay. So,
and does it match what you're seeing?
Yeah. So how did you work with him?
So basically, I got him on the table, and because open chain knee flexion did bother him, I tested it. And the stiff end feel, this is what we would expect, right? So I had him in supine. I just did a basic PA on the tib fem joint, stiff into extension, same thing. Very just articular. This guy had an articular joint issue, stiff and also muscular. Okay. I mean, this is obvious, right? So, but he did have a hard time going into single limb loading and going into full knee flexion. Left worse than right. I had him go on it prone. I tested it as well. Okay, just to see. He was a bit tighter, obviously, because of the pull of the quad. So I had him go back on his tummy. I had him go stay on his tummy. I had him in prone, dorsiflex the feet. So he's going to dorsiflexion, his toes are on the table. And I said, just keep your feet on the ground on the table and just lift your knee up to see if you could go into knee extension in that closed chain position on the table. Okay, so prone, dorsiflexion, the toes are on the table. And he had a hard time with it. A lot of times they're not firing their glutes, but he just was very stiff. So I wanted to see if I could replicate that same feeling I felt in supine in prone. So I turned him back over in supine. And I'm not going to sort of discuss the actual hands-on treatment because, as I said, I wanted to talk about the exercise. So I did your typical, your soft tissue around the joint, then release some of the hamstrings, the popliteus. I did some traditional joint mobilizations that we all learn over the years to the tib fem and the patella, the PFJ. Not so much the superior tib fib, in my opinion. People who have issues like this, the impairment is most likely in the tibiofemoral joint and the patellofemoral joint. Just straightforward basic joint mobs in different positions. I did it in supine. I had him go into I had a bolster under the knees. I did some terminal knee extension, basic motions, right? I had him go back in prone, and then I had him put a bolster under the ankles. I did some soft tissue there. I took the bolster out, had him go into that closed chain knee extension again in prone, and it was better. So, and I did that for a fair bit of visits. And we were moving into exercise. And so this is what I wanted to talk about, because this guy has a hard time going down the stairs and squatting. So would we have him squat first? I wouldn't. I mean, at least not independently.
Unassisted, yeah.
Unassisted, excuse me, exactly. So what I started to do with him, and love your thoughts, because I've had a bunch of stuff, but I actually started, I don't give this exercise out much to people, but I gave it to him because I thought it would be a good way to load the knee in an unobtrusive position. So I gave him like a basic bridging exercise. Just go into supine, put your knees on the ground, push the feet onto the table, and lift the bum up. Then I had him go up on the tabletop on the wall and do the same thing. So he's mimicking a squat, but in a very unloaded position, right? So what do you, and I, because he's looking at me going, is this for my knee? And I'm like, yes, it is for your knee, but I'm not going to start you off with squats right now. I mean, I did give him wall squats facing the wall at some point, but I wanted to talk about him because I think there's a way that we can keep, because I've learned over the years the hard way, that is, depending on the degree of OA, depending on the degree of irritability of these patients, going into sort of an aggressive program makes them worse. And as I said, I've learned that the hard way. Okay. So it just makes them worse. And so I was trying not to baby him because I knew he was very active, but I wanted to be smart about the exercise. So that's why I started him in the bridging and going bridging. And that was actually fairly okay for him. And then I actually had him go on the wall. I put a little pillow or a little ball under his bum as well when he went up into the bridge. So what do you think about that, Susan? I want to
Yeah,
get
I think that's great. I think the other way that you can kind of mimic squatting, and some of the things that I've done too, is like be on their back, 90-90 hips and knees, feet on the ball against the wall, and press into the ball.
So so like
So
a
that
Swiss ball.
they're like, yeah, big Swiss ball. So their feet are right on the Swiss ball. The ball is against the wall, and they're at 90 degrees knee flexion and hip flexion. And they can just work on gently just pushing, so you can do it in various degrees of range of motion. So they can push at 90, they can scoot out a little bit and have their knees bent at 45 and push there. So you can it's like squatting, but gravity eliminated, or kind of squatting.
Got it. So they're pushing their legs into the ball. Got it.
Yeah.
Okay.
Yeah. So that you're creating that closed chain, and they're working in different positions that way too. And I think those all can be very helpful. I think somebody sometimes too, thinking along this line, for the ones that have the cables in their clinic, but the thicker bands.
Yes.
Or a TRX
A
even
TRX.
works.
Yes.
Yeah, you can do some unweighted squatting that way.
Yes.
Which can be very helpful too, so that they can maintain the movement. They can work on the movement. They can clean the movement up, but they're not loading their entire body on it.
Yes.
So you can kind of figure out how thick does the band need to be so that they can squat with help without pain. Can we get them, okay, if it's the position that hurts, then let's stay out of that position and free it up, or is it just the act of loading? Yeah. And I think those things are very helpful too, much like what you were doing, with the various positions on the wall.
Yeah. Yeah. I like the ball because it's a great way, once again, to sort of take the actual squat and flip it in different positions, and with the bridging, that was pretty easy for him, to be honest. But I was like, we'll start there and then we'll go on to the wall. Then I had him do, I put a TheraBand around the thigh just to get the glutes, and then put a ball in between in between the legs. But I like the Swiss ball because that's another way to just train the same thing, but in a different context. We always talk about different context.
It's like standing and squatting on a Bosa ball, but you're doing it laying on your back. And so there's also the various inputs that are coming into the system from the Swiss ball.
Yeah.
So they have to kind of like start playing with balance a little bit, and they can't have their muscles turn on and work the way that they've been doing in a protective sense, because the ball isn't gonna, they're gonna have to, in order to keep the ball from moving all over the place or being able to kind of push into the ball, they're gonna have to change their motor recruitment pattern.
Right. Exactly. Exactly.
Which is, if you put your feet on the wall, you can still do it, but you're not going to get the same feedback. You're going to get that stiff feedback from the wall, and the ball allows for a much more dynamic feedback.
Yes, exactly. And you want to think about the impairment too. Like the impairment for him, like that wasn't really weak. I mean, the guy's 81. I mean, he's not necessarily weak. He was very active. So he had an overactive hamstring, right? And so you want to think about also ways you can sort of take that out, right? And for him, just going on the wall and doing a little bit of bridging in a tabletop was hard for him. That was hard for him. That's hard for a lot of people. But you want to think about, as a clinician, what are you trying to do here? Are you trying to strengthen the quads? Not really. I wasn't. I was trying to decrease the load without activating the hamstring. Bear in mind, this was after a lot of hands-on work, not a lot, but a fair bit. So, I've gotten asked this before, would we do a straight leg raise? I would not personally. I don't necessarily think that's an efficient use of your time or their time. I mean, that's a very basic exercise that we learn, but I don't think that would have been an efficient use of his time, because his impairment wasn't really a weak quad. It was actually it was inhibited. Right. So, for those of the people who don't have, I have access to TRX and I have access to Pilates and,
Pilates is great because you can use the cables and you can use the
chair.
Moving bed.
Yeah,
the
the
springs
reformer.
and
Yeah,
unspring and, kind of work that and work those in different ways. The total gym works.
yeah,
You can get it on a low level or you can raise it up higher, but it still takes a lot of the body weight out of it.
right.
There's
Yeah, and I also think that like I walk up the Pilates chair, so you're sitting on the chair and you're pushing down. There's springs, so you're sitting there and you're pushing down. It's almost like a seated leg press, but you're seated and pushing down like that. But for those of you who don't have access to any of this, like there's no gym equipment, you don't have anything, what else could you possibly do and give your patient? I mean, there are a lot of things. I mean, I
hmm
had him go into prone again and dorsiflex his feet. And I actually had him do like a mobility exercise, thinking about, some imagery in the sense that, and I demonstrated it on myself to show that I wanted him to get I wanted full knee extension in prone. And so when you do that, you have to activate your glutes. So the prone, feet are dorsiflex, toes are on the table, and you're lifting your knee up. You have to fire your glutes and you have to extend your knee. And some people do that with no problem, but he was very stiff. So I had gave him that was more of a mobility piece, but it was in a way training the glutes secondarily, I
hmm
think, as
Yeah,
well.
and then there's a lot of ways you can work flexion extension. If you don't have any equipment, you can use some TheraBand. You can have them get on all fours, and put it around the foot, hold it with the two hands and press out. You can do
Mm-hmm.
it laying on the back, with one leg and pressing out and pulling back in. You can do it with
Mm-hmm.
both legs, both feet in the TheraBand, holding with the arms,
Mm-hmm.
or tie it to something. You can tie TheraBand to the door and have them lay on the floor and press out onto the. There's a lot of different ways you can work this. I
Mm-hmm.
think the idea here was working with him. It needed to be something that was going to be functionally meaningful for him. So I can see doing that with both legs in the beginning and then working into single leg because
Yes.
the bending and straightening with single leg, open and
Mm-hmm.
closed
Mm-hmm.
chain was a problem for him.
Yes. Yes.
So, and, eventually with, even with like, you could think about, step up and step downs with the band, the thicker band so that he can do it assisted. He can hold on to it.
Mm-hmm.
He can
Mm-hmm.
wrap it around his torso and have some assistance while he goes up and goes down
Mm-hmm.
and,
Mm-hmm.
changing that and kind of thinking about all the different ways that he needs to go up and down stairs that are really bothering him.
Yeah. And since
And
he
you can
had,
lighten
oh,
things
yeah.
up as you go. But even if you don't have equipment, you can get some very thick, stiff TheraBand and
Mm-hmm.
hang it from the top of the door and have him work on
Mm-hmm.
it. It's not,
Yes.
you don't have to have a full gym equipment.
No, 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 no. Yeah, because yeah, exactly, and or you just a belt or a strapper or anything, just to, like a
hmm
TRX and that. So I also gave because he had the ankle sprains, his calves were stiff. We walk a lot in New York. Everybody, and you walk a lot, your calves get stiff. So I did give him, some basic stretches with the knees flexed and the knees straight in terms of stretching the calf. I also gave him sling squats, and those are just you're facing. So it's not what you think. I mean, you as being the listeners here. So it's you're facing the wall and you're going into a heel raised position with your knees straight. And then at the top of the heel lift, you bend your knees slightly. And then
hmm
you keep the knees bent and you lower down your heels, trying to be very equal. Okay. You start the next rep with your knees bent. So you're doing a heel raise with your knees bent. You go up and then you straighten the knees out and then you lower down. So it's like a sling squat, which forced him, especially at the top of the rep when he was in the knees flex position and he had to lower down. That's a loading the knee in
hmm
dorsiflexion, which is the same principle as a squat.
hmm
So I was trying to go in the back door with that. So that he felt good with that. So it was heel raises, knees flex, knees straight in a sling. So, but when he went into the top of the lift, bent his knees and he lowered down, that was hard for him. Not painful, but hard.
Yeah, and a way to progress it that's really nice is if you've got the TheraBand or one of those thicker bands that hangs on a bar, you can put his heel goes right onto the band and he stands on the floor. And as he comes up, it's assisted, but as he goes down, it's resisted.
Eccentric, right?
Yeah.
Oh
So
no,
you can
resisted.
so you can kind of load it up, especially for the knees flex going into
Mm,
dorsiflexion with the foot. You're actually loading with that band. So that can be kind of a different way to do it. And then the control on the way up so that the band doesn't just lift them up, but they have to control the resistance of the band going up
yes.
into heel up, toe, into that
So they're
plantar
standing in
flex
their
position.
and their heels are on the band.
Yeah.
Got it. Yes, yes, yes. Oh, that's a good one too. Absolutely.
Hmm.
See, you could, I mean, the whole point of doing this episode is you don't need equipment to treat these people. Okay. And I think so, so I like that one. That's a great progression.
Hmm.
And then sling squats off the wall is very hard to do. But the point is, and I want everybody to remember, is that what's the impairment here? This guy's not weak. Okay. We need to take out his overactive movement pattern, which is a lot of hamstring.
Hmm.
Teach him to stand with his knees straight, although walking was fine for him. He managed pretty okay. And so I started him, so I got him off the table with the bridging, and then I started to do the sling squats. And then what I thought I would do, because I didn't want him to sort of focus on the step up and the step down in the stairs, I started having him doing lateral step ups to
Hmm.
sort of trick the brain a little bit. So he'd step down laterally and he would step up laterally. And he's like, "Oh, that feels pretty okay." I'm thinking of him going down subway stairs sideways. I'm like, "That's not gonna happen." He's like, "Should I do this in the subway?" I'm like, "No, no.
Not
People
unless you want to
will
get run over.
people will mow you down here." Okay, there is no way. So he had like a small. Everyone at some point at least has a small little step or some books or something at home that you could just step up onto, and he could hold on, to something. But the thing with him is I felt that he needed to be able to get his knees straight actively, and uh, because I didn't want him to get really stiff, and
Hmm.
his standing with the knees flexed like that was just a motor pattern that he just did over the years to pain. It's an avoidance pattern, right? So that
It's
was
just
one. Mhm.
it's just this motor system trying to pull him into a little bit of open chain.
Yeah, yeah,
I mean, not
yeah.
open chain, open packed,
Open packed.
open
Right,
packed position. But the knee close packed position for nutrition,
right,
they do. And so over time, it does become problematic. And it just takes time to kind of move back through that. But it's really, like you said, there is, joint dysfunction for sure. But there's also this overprotective motor plan too, that if you can get that to change up, you can give them freedom of movement again. Because one of the things that, when we're stiff like that, or when we're holding ourselves stiff like that, we start limiting our balance.
right,
We
right.
become a vase instead of a willow tree.
Yep.
And we're not as adaptive in our movements. And he wants to run, he's going to need to build some adaptations or
Hmm.
adaptivity, the ability to change and to flow along a little bit more, because it's going to be fatiguing to run being that stiff, holding yourself that stiff. We want him to be
Yes.
looser and,
Yeah.
you
Yeah.
know,
Yeah, exactly. So even if he runs a few minutes, he actually was running a couple miles. And he's able to straighten his knee out. And, I said to myself, look, your system needs choices for movement. Whether you take those choices is up to you, but you need to be able to go there. So what I ended up I did eventually get him squatting, obviously, but he did standing body twists in his calisthenic routine in the morning. And so I talked to him about when you're in those positions, you can vary your foot position, normal, sort of space of support, narrow and wide, and just do some body twisting and think about moving, let's do an awareness. Let's go down to your hips, let's go down to your knees, let's go down to your feet. Let's see if we can get them moving and gliding a little bit in an exercise that you're already doing, in the morning, right? Sort of like your Jack LaLanne type exercises, right? So the movement patterning. So then I gave him some basic wall squats, hands on the wall, and I progressed him from there, normal, narrow, wide progressions in base of support. I actually had him do very small not sling squats, those I did those split squats, but I did them so I had his more painful side was his left side. So I had his right leg forward and his left leg back, and just like literally a millimeter down, just do a little millimeter down, a millimeter down, and holding onto the wall, a millimeter down. And I had him also just we have access to a fuse ladder. So here I had him hold on to the ladder as well, push down on the it's like parts of the ladder. So you're pushing down, activates his abdominals a little bit, and then he goes down and up, down and up.
hmm
And he could do that at home. And so, but I had his significantly symptomatic side back first, back.
hmm
So because it was aggravating him the other way. So that's how I started. And that's actually how I ended him, because he was doing much better with that. And I think that if I had started him with, upright activities, I think that would have made him worse to start with, which is why I
Mhm.
did a lot in supine and prone and bridging and things like that on the table. Do you have any final thoughts on that, Susan?
No, I just think that, clinical reasoning,
Yeah.
he was having a lot of trouble with the stuff in open and closed chain,
Yes.
so there wasn't, so some of the things is like, how can we adapt this to get him to start using a different motor pattern that isn't going to be also painful?
Right.
And, so using the tools that you had, we're able to get him to start using his muscles in different ways to gain the range of motion without pain.
Yeah.
And then
Yeah.
you started progressing him, more and more upright to where
Yeah.
he was, able to do some really good exercises and activities
Yeah.
that would have been hard to do in upright in the beginning because of his over recruitment pattern.
That's exactly right. And would I give him leg extensions and leg curls? No, no. And in open chain, the minute he just actively flexed his leg in supine 90-90, his hamstring kicked in. Of course, I mean, that's what's supposed to happen, but it was just way dominant, right? And
Hmm.
I didn't really train a ton in open chain with him, but it carried over. I did a little bit, obviously, but it was mostly just trying to put him in positions that would take out that overactivity and get him to, it's almost like graded exposure in a way. I'm sort of pushing him into a full squat or a single squat. And he actually ended up doing it. So
Hmm.
doing it okay. And who knows? I'm still treating him. Maybe he will run a marathon. My guess is he probably will at some point. You never know, right? So, but I wanted to bring, as I said, I wanted to bring this up just because of the nature of the exercise progression, because I do think we can be a little bit aggressive here, with some of these patients. And I think that we need to sort of mix things up and change context. And straight leg
Hmm.
raises and extensions and leg curls are really probably, I think, not the best way to start. So
And generally, that's what everybody's doing out there
I know.
already. They're coming to you because they're doing this stuff and it's not helping.
Hmm.
So, what can we do that's different?
Yeah, flip the
Because they may
script.
already be at the gym doing, squats and leg presses and open chain, knee extensions and hamstring curls, and they're not really they're feeling stronger, but they're not really feeling much of a difference, perhaps in their knee. We're just focusing on the knee right now. And so how can we do things different? Another way that to kind of train knee flexion and extension and closed chain and to also get people cardiovascularly fit is put them on the row machine.
Yeah. Yeah.
You know, rowing works.
Yes, it
And
does.
and they don't have to go as far. It can be like, you can set it to where this is as far as you go.
Hmm.
Let's just work through this range of motion here and not worry about work, coming into full flexion where it really hurts. Let's stay out of that, but let's get that going. And they have to use different muscles to be able to row. Plus they're getting the upper body work too, which is kind of nice.
Yep, absolutely. I agree. Awesome.
Awesome. Okay,
Well,
thanks everybody.
hope you enjoyed it, and we will see you on the next episode. Bye.
Bye.